Video 9 of the algorithm for the psychopharmacology of major depression from the Harvard South Shore Psychopharmacology Algorithm Project. We are working our way through the main algorithm for major depression in outpatients and the few remaining inpatients that didn't have severe melancholia where you would be thinking of an antidepressant. In the previous video, we talked about the first trial and what we recommend for the first antidepressant. And now we're at the second trial. The first one has failed, and what are we going to do next? One of the toughest decisions in psychopharmacology, because there's such a huge amount of study of things that you could use after a failed trial, but almost no direct comparisons of one thing with another. So here's how we approach it. First, review diagnosis again, as you should after every failed trial for anything. If you think it's unipolar depression, but it's bipolar, you could be wasting a lot of time or worse in treating this patient. So recheck your diagnosis after each failed trial. Significant others, by the way, may have better insight into the occurrence of discrete episodes of hypomania or mania that are occurring. So getting permission to and then checking with others who know the patient well may help understand why your treatments aren't working and lead you to a correct diagnosis. Now, as I said in video 8, many have wondered if it's better to switch or augment after the first failed trial in major depression, although there is little evidence. And perhaps the best study was STAR-D that compared patients who chose a switch for their second trial versus a group who chose augmentation, and they matched those patients to have similar demographics and severity. They found an odds ratio of slightly better results with augmentation of 1.1, which was not statistically or clinically significant. So therefore, in this algorithm, as in STAR-D, we let the patient decide if he or she wants an augmentation or a switch. We offer 4 choices for switching, what we think are reasonable, well-established choices, and 4 for augmentation, which we think are among the best of those. And then the patient will sometimes prefer an option with fewer studies, maybe, to show efficacy in order to have the minimal side effects of them, as opposed to picking maybe an FDA-approved option that has had many studies supporting efficacy, although not better than other treatments, but with considerable side effects. The best example of that would be the second generation or atypical antipsychotics, some of which are FDA-approved, but they have a big side effect burden. So let's go over our options. First, we have the switching options. We have 4 basic choices here. The first is to switch to one of the agents we recommended for the first trial that you didn't try yet. So that's either sertraline, escitalopram, or bupropion. There have been studies showing up to 70% response rates after 2 or 3 consecutive monotherapy trials. No significant difference has been found for switching within or between classes of antidepressants in 2 big meta-analyses. So you could do a different SSRI, or you could switch to a different class, like bupropion. Now, the second switch option is to switch, instead of one of our 3, to a dual-action agent, something inhibiting both norepinephrine and serotonin reuptake, and here the choices would be venlafaxine or mirtazapine. There are some reports favoring switching to these agents. They're mostly funded by their manufacturers. However, in STAR-D, there was an option of switching to venlafaxine. There was a numerical trend in favor of it over the SSRI switch. It was 25% remission on switch to venlafaxine, only 18% on sertraline switch, and 21% on bupropion switch. That was not statistically significant, but it's a slight trend. The downside of venlafaxine is it can elevate blood pressure, has more severe discontinuation syndromes, more GI side effects, and more overdose fatalities. The mirtazapine switch is another option. It may work faster than other antidepressants, according to some reviews, but not better by 12 weeks. Weight gain must be actively monitored. There are rare cases of agranulocytosis. The third switch option is switching to regional transcranial magnetic stimulation. It's less invasive, better cognitive side effect profile, but less effective than ECT, and basically has very few side effects. Very expensive, though, but some people can afford it. The FDA has approved RTMS after you have failed 1 medication trial, but not 2. Did you know that? It was the data that was presented to the FDA for people who had failed 2 antidepressants didn't show any difference from sham. So the FDA approved it only if you've had 1 trial. And finally, the 4th switch option is a switch to an over-the-counter, non-prescription herbal or vitamin-like agent. And in that category, we offer 2 that have decent evidence of effectiveness: S-adenosylmethionine, or SAMI, or St. John's wort. They have fewer side effects than antidepressants, and the patient may want to give one of them a try, even though they don't have a lot of data. So in summary, the key points of this video. After the first failed trial of an antidepressant for major depression in this group of patients we've been discussing, let the patient decide if he or she wants to switch or augment that antidepressant. This is what was done with quite useful results in the STAR-D study, and we adopted it as a strategy for use in the algorithm. There are 4 choices that we offer for switching, and then 4 for augmentation. Each has its advantages and disadvantages. We recommend suggesting all, or perhaps some of the 4, and those were choosing another one of the Node 4 choices for first-line treatment, namely sertraline, escitalopram, or bupropion. The second choice could be a dual-action agent, venlafaxine or mirtazapine. A third would be transcranial magnetic stimulation, or rTMS, is a reasonable and FDA-approved option for people who have failed 1 antidepressant trial, but not approved if they've been given 2 or more. And finally, S-adenosylmethionines, known as SAMI, or St. John's wort, have significant evidence of effectiveness in major depression to make them worthy of consideration for a person who's looking for something with practically no side effects and is easy to obtain. We will discuss the augmentation choices in the next video.